Hello everyone. Today I'm going to present my case on root canal treatment on tooth 45. The patient is a 30 years old Thai male. He came with a chief complaint of sensitivity from cold water on tooth 45. The patient has a history of appendicitis. He had a major surgery to have the appendix removed 10 years ago at Lana Hospital. He also has been a smoker for 2 years, and he smokes 5 cigarettes a day. He has a dental history of having extractions on 26, 38, and 37. They were all retained roots. His questionable dental hygiene, coupled with smoking habits, might have led to dental caries and eventual extractions. This is a panoramic radiograph from 3 months ago. The general alveolar bone loss is about 40%. There are many retained roots in the molar area. The retained roots on the left side have all been removed. The patient still needs to have 1/7 and 1/8 removed. Now to the tooth in question, that is 45. On the day of shutting, his blood pressure and heart rate were within normal limits. Tooth 45 has the following symptoms. The patient started having spontaneous pain, which started about a week prior to the appointment. It also is sensitive to cold water. The pain from cold water lasts about 4 to 5 seconds. He reported that the pain is mild with a sharp characteristics. It also doesn't radiate to other areas. Upon intraoral examination, caries exposed pulp can be seen on occlusodistal aspect. As for these exams, 3-5 were chosen to be the control tooth. Electric pulp tests on both 3-5 and 4-5 give positive results. Other test results on tooth 3-5 were within normal limits, while tooth 4-5 were positive on cold and heat test and negative on percussion test. Both teeth have first-degree mobility due to generalized alveolar bone loss. Probing depths for both teeth were 2 to 3 mm. Radiographic findings showed caries exposed pulp on 4-5 distal, which is about 4 mm in diameter. The pulp chamber, the root, and the canal appear to be normal. Periradicular area showed widening of periodontal ligament space. Alveolar bone loss is generalized. Tooth 45 was presented with spontaneous pain and sensitivity to cold water. Intraoral exam and radiographic image showed that there was caries exposed pulp, but it is negative to percussion test. This led to the conclusion that the diagnosis is symptomatic irreversible pulpitis and asymptomatic apical periodontitis. The treatment plan for this tooth is non-surgical root canal treatment with post and core with crown for final restoration. Preoperative treatment is caries removal and dam construction. Anesthesia is required because the pulp is still vital. Anesthesia injection was then performed with inferior nerve block and buccal infiltration. Caries removal revealed pulp exposure site to be seen. Resin composite was used for dam construction. The patient was told to bite on articulating paper to check proper occlusion after direct restoration. And here is before and after the filling. On the second visit, the tooth didn't provide 4-point contact for the clamp due to cervical abrasion. All the available clamps were loose as a result. Class 5 restoration with resin composite were done to achieve optimal contact for the clamp. After proper rubber dam isolation was achieved, inferior alveolar nerve block was performed before finding the canal with round diamond burr. There was only one root canal found. File number 10 and 15 were used for coronal flare. In the third visit, the steps from length determination to trimane cone was completed. Electronic apex locator was used with file number 20 to measure working length. It was 19 millimeters. The reference point was the tip of the buccal cusp. Initial apical file was number 20, and file number 35 was chosen to be the main apical file. Mechanical instrumentation was done with passive step-back technique until stopping with file number 80. Canal patency was achieved with regular irrigation and small files. Tuckback was present when Katapacha 35 was used. Root canal spreader D11T was chosen according to suggestion from research. Periapical film was taken to ensure proper working length. The patient was appointed 7 days later for the next visit. On the fourth visit, the patient reported no symptoms. Extraoral and intraoral examination found no ongoing pathology. Temporary filling was then removed, and calcium hydroxide was examined using file number 15. The medication appeared to be white, odorless, and sandy. No active exudate was found. Trimane cone was done again to ensure proper length. CMU protocol was performed with 17 EDTA and T2.5 sodium hypochlorite. Lateral compaction technique was used for root canal filling, and after significant amount of accessory cones was in the root canal, periapical film was taken to check for void. The film showed void at the middle third of root canal. To achieve homogeneous filling, excess coronal catapacia was removed with heated endodontic plugger. More accessory cones was added to the canal by using the smaller D11TS root canal spreader. Vertical compaction was also performed. Second periapical film was taken. The root canal filling was now homogeneous and well adapted to the canal wall. But catapacia removal was not adequate. There was still residual catapacia on surrounding canal walls. In this recheck visit, SOAP method was used to assess the tooth. The root canal filling was still in good condition, and the patient reported no symptoms. The outcome of this root canal treatment was favorable and is ready to be referred for post and crown core with crown in a few months. Temporary filling was then replaced with Fuji 7, but there was void in the filling. On the second recheck visit, base filling with Fuji 7 showed no void. Coronal seal with resin composite filling was done, followed by finishing and polishing. And here's the final look of the tooth after root canal treatment was done. The patient was referred for post and core with crown treatment in 3 months after the recheck visit. Endodontic recall step will be done on the day of shutting in restoration clinic. A study by Heraller et al. Investigated the effect of remaining dentin wall thickness on the fracture strength of root canal treated teeth. It was found that endodontic pose is necessary in root canal treated teeth with less than 1.5 milliliters coronal dentin wall width. There's also another concordant study by Ibrahim et al., which assessed the effect of remaining tooth structure on the fracture resistance of root canal treated teeth. It was concluded that there was a positive linear relationship between the remaining coronal dentin surface area and fracture strength. A review on which type of post to use is also important. Martinez et al. Compared fracture resistance of pulpless teeth restored with cast post and core or carbon fiber post with a composite core. The conclusion was the post-encore group had significantly higher fracture strength. Endodontic post failures are usually not repairable and eventually led to the tooth extraction. The dentist should inform the patient the possible outcome of treatment choices. Incorporating post in the treatment plan is necessary if significant loss of coronal dentin is observed or expected to occur. The study by Hilaire et al. Is in agreement with the study by Ibrahim, which reported a significant relationship between the remaining coronal dentin surface area and fracture strength. Groups with less remaining walls showed the lowest mean failure loads. The patient in this presentation previously had caries exposed pulp on distal side of the tooth. After caries removal, the tooth was left with only one proximal wall or only 3 external walls. The buccal wall had its dentin completely removed. Hence, the final restoration is cast post-encore with crown. But it should be noted that the patient is missing multiple posterior teeth and removable partial denture is indicated. Survey crown will be done with interdisciplinary treatment from prosthodontic clinic. Thank you.